Ein bisschen dunkel. Ne? Ah, wir sind schon da. Hello, everybody. A very warm welcome from Hamburg, Germany to today's session from Weinmann Emergency. This is Vanessa Kühn, Product Manager at Weinmann Emergency in Hamburg, and Professor Dr. Clemens Kill, streaming live from Hamburg. Let's start with a presentation. A very warm welcome to today's event. My name is Vanessa Kühn and I'm Product Manager for Emergency and Transport Ventilation here at Weinmann Emergency in Hamburg, Germany. And today we have prepared a topic, a very important topic, mechanical ventilation during resuscitation. For this, we will see a presentation on the theoretical background of mechanical ventilation in resuscitations, and afterwards a short live demonstration. After the live demonstration, you will have the possibility to ask questions via the chat. If there are any questions during the presentations, please write them in the chat and we will sort them and answer them afterwards. And now I am very happy to introduce to you our speaker of today, Professor Dr. Clemens Kill, Director of the Center of Emergency Medicine at the University Hospital in Essen, Germany.
Welcome to all. My name is Clemens Kill. I'm working at the Center of Emergency Medicine at the University Medicine of Essen in Germany. And I'm happy to present you now a presentation about mechanical ventilation and resuscitation. When we speak about ventilation and resuscitation, the first thing is that we need ventilation as we always need it for CO2 removal, as we do it with each patient we want to ventilate mechanically. But there is another situation compared to normal patients, because we have no beating heart and we have only circulation caused by chest compressions. So the situation is completely different to ventilation of patients normally alive. And we have to consider these circumstances in further evaluations. If we speak about chest compressions, we have to get a look how chest compression work. And there are two theories how chest compression work. The first is you compress the heart directly and squeeze out the heart to pump the blood into the body. The second theory is that we have a kind of thoracic pump, that we compress the whole lung within the vessels, and by this mechanical compression we squeeze out not only the heart but also the vessels through the lung to push the blood forward into the body. Nobody knows exactly which part is the major part in which patient, but both parts seem to be important for the work of chest compressions during resuscitation. And it's very important to have a look onto the lungs if we speak about ventilation during resuscitation. So when we have a look to normal ventilation with intermittent positive pressure ventilation, we have a typical curve of pressure and flow with a constant flow with the volume controlled ventilation. Everybody knows these curves. If we do chest compressions during IPPV ventilation, there are big disturbances caused by the air that is squeezed out of the lung with each chest compression. So we have small volumes just going out and into the lung that make a kind of overlay over the curves of flow and pressure, so the curves are totally disturbed compared to the normal curve flow. If you ventilate with BiPAP or bilateral ventilation, it's nearly the same. We have the typical pressure-controlled pattern of the curve with a decelerating inspiratory flow. And if we do chest compressions, these curves also are disturbed a little more than the IPPV curves, because the valves of the ventilator are both in the in and in the expiratory position open, so the air might flow in and out without any disturbance. So mechanical ventilation is normally controlled when the patient does nothing and doesn't breathe at all. So the ventilator controls anything, or it's assisted as an assisted spontaneous breathing when the patient triggers an inspiratory support with each inspiration effort he does. Now we have the situation of resuscitation, and resuscitation means that cyclic inexpiratory gas flows with low tidal volumes just going in and out of the ET tube caused by chest compressions make a total different situation, and we can conclude that conventional ventilation modes are not designed for these small flows going in and out during resuscitation because they are designed for patients alive. Here you can see a special picture of a paper out of the 70s of the last decade, where Criley did some observations in the cath lab. Here you can see the ECG with ventricular fibrillation of a patient that gets a defibrillation and then conversion to normal rhythm there. And below you see the invasive measured arterial pressure. Here you see the normal pressure curve, and here you see very high pressures with a lower frequency. And what happened? This patient got ventricular fibrillation, and when he was still awake, he was called to take very heavy cuffing. And by cuffing, the pressure in the chest changed suddenly, and with these cuffs, he was able to produce a forward blood stream. You know these curves out of the, for example, the ICU, when you do suctioning through the ET tube in a patient to cuffs, you have this high pressure waves in patients alive too. But these are very, very impressive, these pressure valves, caused only by changes of the intrathoracic pressure. That shows that it's important what happens into the chest during resuscitation. These observations led to a new concept of ventilation that's called chest compression synchronized ventilation, CCSV. If you have a normal situation with chest compressions and ventilations, you have a symbol of a chest with a heart inside. Now you compress the chest, and there is some blood squeezed out of the heart into the vessels, into the body, but there's also air coming out of the tube, out of the lungs, as a kind of loss of pressure during that chest compression. With CCSV as a ventilation mode, it is designed that you have a synchronized ventilation with each chest compression that is very short, about 200 milliseconds, has a relatively high peak pressure of 45 to 60 millibar, and is synchronized with each chest compression, so that each time when a small amount of air is coming out of the tube, the ventilator insufflates. It's just the other way around as you have it with the assisted spontaneous ventilation, where the inspiration of the patient is the trigger. Here, a kind of expiration out of the tube caused by the chest compression triggers the ventilation. So there is no loss of pressure as you have it normally, but instead you have an additional pressure coming into the lung, squeezing more blood out of the inner volume of the whole chest into the body and the vessels. This is the idea of chest compression ventilation, to support chest compressions by synchronous ventilation. If we look to the curve of this ventilation mode, there's nothing to see if there do no chest compressions. But if you do chest compressions, you have the synchronized short time, low volume ventilation that is up to 120 times per minute, depending on the exactly frequency of your chest compressions. And how are the results of this new compression mode? Here I brought you a picture of the first experimental data of chest compression synchronized ventilation in animal research. Here we have a arterial partial pressure, PaO2. This is the baseline before start of the experiment. With normal room air, you have 80 to 100 PaO2. And here you can see the three groups: dark blue bilevel, green CCSV, and light blue IPPV. And here you have 4, 7, 10, and 13 minutes of resuscitation with a non-beating heart. And you can see the arterial partial pressure depending on the ventilator mode with pure oxygen in ventilation. And here you can see that the standard ventilator modes have not very high values of 150, for example, whereas CCSV is much more higher and significantly better oxygenation of the patient. Another series showed just the same, compared IPPV and CCSV. This is a baseline, 8 minutes, 12 minutes of resuscitation with highly significant better oxygenation of the CCSV group in an experimental setting. So the first thing that ventilation has to do to provide oxygen into the arterial blood seems to be very good when using an alternative ventilation mode called CCSV. But there is another effect, as I showed you with the principle of CCSV. Here we have pictures of experimental blood pressure curves. The red one is the arterial pressure, the blue one is the central venous pressure, and the difference between these curves is the resulting perfusion you have to perfuse the body. Here you can see quite low values of arterial pressure. It's between 20 and 40 because it's an experiment without epinephrine. And if you have some minutes of chest compression, the blood pressure, even in human beings, often is very low. Now, this situation is without doing ventilation in the same period. And when we now switch on CCSV as a ventilation mode, you can see with the green bars the time frame where CCSV insufflates the oxygen into the lungs. This is exactly with the start of the chest compression, and the immediate result is it's just 1 second later compared to the left graph. Immediately the pressure, the arterial pressure, rises much above the level of the non-ventilated time frame. So we have a better area under the curve, a bigger one, and a better perfusion. And this is not a single effect of one animal. I brought another 3 ones. These are 3 animals of the investigation. On the left side, you have CCSV. On the right side, you have no CCSV. And you can see the sudden drop of the arterial pressure in all of these 3 animals. And if you just switch on CCSV again, it's just the other way around. So it's an immediate improvement of arterial perfusion by using a synchronized ventilation. So we have a quite good oxygenation and we have a better perfusion in the arterial system. So we have to answer the last question: is it a better perfusion or better oxygenation for the tissue too? And here we have data of a cerebral tissue oxygenation measurement with implanted probes into the cerebral tissue. And we can see, compare the 2 groups, here the values of the baseline with room air. Normally the tissue is about 50% saturation. That is nearby the venous, the mixed venous saturation or the venous saturation. And when we now start resuscitation, 6 minutes, 10 minutes, 12 minutes from start of cardiac arrest, we can see that even with 100% oxygen in the ventilation, we have critically low or lower values in the tissue oxygenation than with room air before. And we can also see that only CCSV has, with a median, values compared to the normal range, and IPPV is in the majority much more lower and probably too low. And only if you inject epinephrine, the values in both groups get better because epinephrine improves the perfusion of the brain with a vasoconstrictive effects in the other arterial system. So we can see that also in this setting, CCSV provides a significant better oxygenation of the critical cerebral tissue than IPPV as the final result of the combination of oxygenation and perfusion. Here I brought a graph out of a ventilator with human resuscitation. Here can you see on the left side the curves of CCSV with the pressure and the volumes. Then there is an interruption of chest compression for kind of rhythm analysis, and the restart of chest compression with a restart of synchronizing of the ventilation. If the patient once has achieved ROSC and is switched to IPPV ventilation, and now, for example, there is VF again, and the patient has a second cardiac arrest, then you restart the chest compressions. You can see here in the first part, this is the normal IPPV curve and flow pressure and flow curve. And now you can see 5 compressions in a way we saw it in the beginning of the presentation with the disturbance of the IPPV curve. And after 5 continuously compressions, the machine recognized, oh, there are chest compressions again, and starts CCSV again with a CCSV pressure and flow pattern. Here you can see it compared directly to IPPV. This is just an example out of practical resuscitation life. There's one important thing you should know when you should use CCSV. Normally, we have a capnography as a kind of indicator for pulmonary perfusion. So many people say the better the value, the higher the value of EtCO2, the better the perfusion caused by chest compressions should be. So normally we have with IPPV values that should be above 10, could be up to 20, and a curve that is, for example, as this curve, sometimes you have these disturbances of the chest compressions also in the CO2 curve. When we have ventilation with CCSV, we have a much higher frequency, and we have a typical EtCO2 that it's about 5 to 15. And now many people think it's worse than the upper one, but this is not really worse. It's just caused by a technical topic. If you take this curve and make an overlay over the normal curve, you can see that there is not enough time to reach these high values because the next inspiration starts. So it's a technical measurement topic, not a topic of better or worse perfusion or better or worse ventilation. It's just caused by the technical mechanism of capnography. So don't worry if you have CO2, it doesn't matter if it's low or not during CCSV, because it's not, you only see the high values if you have an interruption of chest compression and the expiration has much more time to reach the high values in the end of the curve. So it's just the limit of the curve. Let's have a look to the results in human use of CCSV. We have some preliminary data of the Cologne Fire Department in Germany in situations of resuscitation. Here you can see on the left side in green the results of Cologne, and in black the results of the German resuscitation registry as a kind of benchmark. And here you can see that the percentage of return of spontaneous circulation and discharge alive seems to be higher than the benchmark of Germany. We have nearly 62% ROSC rate and nearly 15% discharge alive. These are quite small numbers, so we didn't any statistics with it. But we did another observation. If we look to the 5 survivors discharged alive and in good cerebral condition, we found times of use of CCSV up to 40 minutes, continuously ALS and CCSV ventilation, but it's a very, very long period. And normally people don't survive such long resuscitation periods. It's impressive that it's possible to use it over such a long period and it works and the patients survive without cerebral damage. So there are many hints out of experimental studies, out of practical experience and human use that CCSV provides many, many advantages over IPPV ventilation. So let me conclude these facts for you. First of all, only CCSV is a ventilation mode that is especially designed for cardiopulmonary resuscitation and is adapted to the special situation of chest compressions during ventilation. It improves the oxygenation, it improves perfusion, and therefore, in my opinion at least, and I hope there will be an increasing number of scientific data that show the same aspect, there is no more need for IPPV during advanced life support when CCSV is available. Thank you very much for your attendance.
Now, Philipp Fuchs, paramedic from the German Red Cross, and I would like to demonstrate you how CCSV works. For this, we have our patient Annie here. She's already intubated, and our Medomat Standard 2 ventilator. To start CCSV, you only need to push one button, CPR, and then choose the patient group, and then ventilation automatically starts when chest compressions start. As we heard before, we have here a ventilation which is synchronized with the chest compressions, and in the case of the chest compression, the ventilation is applied. So the lung is filled with air during the compression, and in the decompression, the air escapes from the body, and with that, we can enhance the blood flow to the brain and to enhance also the oxygenation. We see here chest compression synchronized with ventilation, and on the display of the Medomat Standard 2, we see the frequency of the chest compressions with this little tachymeter, and also if Philipp now stops the chest compressions, we see the hands-off time, which is counted here, and we also see no ventilation happening here. So in the case of the analysis of the defibrillator, you have no artifacts from ventilation. In the case of a return of the spontaneous circulation, the device automatically switches after a preset time to a backup ventilation. In that case, this is IPPV controlled ventilation. So if the patient has a ROSC, but then starts to have a cardiac arrest again, we just need to start the chest compressions, and automatically the device recognizes this and switches back to CCSV ventilation. CCSV can not only be used with manual chest compressions, but also with automatic chest compressions. For this, you just need to set 1 point here, and then the device is ready for mechanical chest compressions. Thank you, Philipp, for the demonstration. Thank you, Annie, and thank you for listening. Okay, so regarding the CCSV, we always have frequently asked questions, and one of the questions is the volume that is applied adequate during ventilation?
Very good question, and really frequently asked questions. We have to do some calculations to answer this question. If we compare IPPV and CCSV with the minute ventilation volumes, we first have to check how we could measure and calculate these volumes. And if we are interested in the real effective alveolar ventilation volume per minute, we have to take the tidal volume, have to take the difference with the dead space and multiply it with the respiratory rate. So if we assume that a patient with an ET tube has about 1 milliliter per kilo upper lower airway dead space, plus about 30 milliliter by the ET tube and the ventilation hose cost, we have about 100 milliliter that is not part of the alveolar ventilation, but it's a real kind of dead space. So if we have IPPV with a frequency of 10 per minute and a tidal volume of 600 milliliter minus 100 milliliter, we have an effective minute volume of about 5 liters. When we do the calculation with CCSV, and we have a 10 times higher frequency of ventilation, but a tidal volume that's about 2 milliliter per kilo, about 150 milliliter, with 100 milliliter dead space, we have about 50 milliliter per breath effective ventilation that is per minute 5 to 6 liters. So it's much comparable to IPPV, and it's not too much and it's not too low. And if we check how the IPPV works during resuscitation, we have to look to some other measurements too. We did an investigation comparing the ventilator presets with the achieved volumes or pressures. If you compare IPPV, the green bar is the tolerated range of the preset volume. We checked that in the simulation with volunteers and with a special mannequin, that more than half of the ventilations were too low, lower than the preset volume. And with bilevel, the pressures were too high. So the presets of normal ventilation modes are disturbed, and the performance is not so as it should be. And in the result, if you show experimental data with IPPV and CCSV with a CO2 in the arterial system, we also can see that CCSV, the blue bars, stays on the 40 baseline during resuscitation, whereas IPPV does not provide a normal CO2, but there is an increase possibly caused by the too low volumes. So CCSV is not only comparable, it seems to be better for CO2 elimination than IPPV does. So I have no fear that it's too much volume or it's too low volume. It seems to fit perfectly.
Okay, so thanks for the explanation. So to conclude, we can assume that the volume is just enough to ensure the correct ventilation, but also not too much to hyperventilate the patient in the end. Another frequently asked question is always the question about the inspiration pressures. So with CCSV, to ensure the positive effect, as you said before, on the circulation, we need inspiratory pressures of 40 to 60 millibars. Isn't that harmful to the lungs, to the patients?
Very good question too. If we look to the peak inspiratory pressure, both in IPPV and CCSV ventilation, we should imagine what happens during CPR and ventilation. If we have IPPV as a ventilation mode, we first insufflate, for example, 600 milliliters into the lungs up to a peak pressure of 20 to 30, 25, anywhere there. And afterwards, at least sometimes, we compress the lungs and the valve is closed at the tube. So there is 600 milliliter additional volume inside of the lungs, and we compress, and we do not know how the pressure rises inside there because we can't measure it. And it must raise, it's normally. And if we have ZCSV, the way is just the other way around. So we have first the start of the compression, and when the compression is already ongoing, the ventilator insufflates a much lower tidal volume than in IPPV with a pressure limit of maximum 60 millibars. So we assume that the pressure inside of the lung may be also lower than in IPPV, but not much higher, because the volume is lower that is insufflated. And we have no data that prove that there is any harm in histological examinations of the lung tissue or an increased ratio of, for example, pneumothorax following CPR with CCSV with the higher pressures, because the volumes are lower. And I'm convinced that it's working without doing any harm, but doing positive effects with these relatively high inspiratory peak pressures.
Well, thank you very much, Professor Kill, for this answer. I think also the data from the fire department of Cologne speaks for this. We had their patients that were ventilated with CCSV for 40 minutes and still with a good outcome. So I think this speaks for itself. So thank you very much, and also thank you to the audience for listening. Well, thanks a lot for this presentation. And we have some questions here in the chat. And the first question that I have not answered yet is from Michael Bobin. And this is to Professor Kill. Do you have first data from the Vienna or the Austrian study centers?
So I don't know if anybody is listening to it. You can see me. Okay. Not yet. Unfortunately, not yet. There are a lot of centers or agency or emergency medical services using CCSV or starting to use CCSV in the routine use, but there are only small numbers in the special centers or services yet, and we are also very curious how the big numbers will be if we take them all together. But we do not know data from Vienna yet, but we hope to get them soon, or to see them soon too.
Thank you for this answer. So we have another question that I might be able to answer too. This is from Guido de Roy. Hope I pronounced it correctly. Is the software mode also made available for other ventilators or for other ventilator manufacturers? I have to answer this with a no. This ventilation mode is only available for the Weinmann Medomart Standard 2 ventilator, and then it was developed exclusively because it was developed by Weinmann. So we have also another question here from Helge Junge, and I would give that one also to Professor Kill. So the question is, what are the effects on pressure and volume in combination with chest compression devices such as autopause?
So all the chest compression devices just do the same as you do with a manual chest compression. They do it more precisely, and all these devices work together with CCSV in practical use too, because the trigger technology works as well as with manual compressions. The experience we, for example, ourselves did in the emergency department in combination with the corporal CPR device is that it works quite well, and the effects of the change in the blood pressure curve is in the visible watching even better or higher than it's with manual chest compression. So it works, but as we have it with the survival data, there is insufficient data yet to see the effects on survival or on the hemodynamics in real life resuscitation situation. But it works with all the devices without any technical problems.
Thank you, Professor Kill. And we have another question from Mr. Uwe Kreimer. And the question is, do you have more profound results from CT scans after resuscitations, since ventilations and compressions were shown to result in severe injuries to abdominal organs? I will also hand this to Professor Kill again.
Thanks to Uwe for this question. This is a question, as I remember, focuses mainly on the autopulse technology, where you have also the compression of the whole chest as an additional effect for the enhancing of perfusion. And there are some data or some case series with some injuries of the parenchymal organs in the abdominal area. So in the practical use in some locations where we do routine CT following both use of chest compression devices, but only with a coupled CPR together with CCSV, we see no differences in the first experiences in the CT concerning injuries. And I can imagine what's the difference between normal ventilation CCSV concerning the injuries of the abdominal organs, because we do not see that there is a venous backflow caused by CCSV, as we sometimes watched it in the case series with autopulse and patients with pulmonary embolism. So in this special situation, so we made no observations, but as I told before, there is insufficient data with a routine CT scan following CCSV with big numbers.
Thank you, Professor Kill. And we hope, of course, that we are able to get also more data on this in the course of the following year, for example, from emergency departments in Europe. So as I see, there are no more questions in the chat. So I would again thank you all for watching. Yes, wish you all a very pleasant ERC Congress virtual 2020. And maybe some words also from Professor Kill again.
From my person also, thanks for watching. Do not hesitate to write me an email or send me any other message if you have further questions or even concerns. I think it's very important to speak about experiences and to share data about new devices, because it's difficult to do all the investigations as prospective randomized trials in resuscitation research. So do not hesitate to get in contact to proceed in talking about the advantages and perhaps possible disadvantages. So don't hesitate to contact both me or Weinmann if you have any experiences or any more questions following the sessions or anytime else. Thank you and have a nice day and nice rest of the ERC Congress.